So yes, we had an educational from the European group this morning on ALL, and we discussed implementation of immunotherapy for frontline Ph positive and Ph negative B-ALL. And so just to remember that we made some progresses for young patients implementing pediatric-like chemotherapy, but this has some limitation for elderly patients where we cannot apply such a regimen. So the aim of immunotherapy is, of course, to improve the response rate, to decrease the risk of relapse, but also to discuss how to de-escalate chemotherapy in older patients to decrease treatment-related mortality, and also perhaps to decrease the necessity to bridge the patient to allogeneic stem cell transplant. So in elderly patients, we have now three phase 2 studies that suggest that the combination of Inotuzumab plus low-dose chemotherapy in induction yields high complete remission rate, more than 90%. That is far higher than what is expected with chemotherapy alone, and that this patient can be consolidated with a very low risk of treatment-related mortality, and that if we expected with chemotherapy alone to have a 10 to 20% of long-term survival, now we can reach 40 to 50% without bridging this patient to allogeneic stem cell transplants. But a huge progress, and these results were provided by the EWAL-INNO study, by the MD Anderson study, and initial study. These two last studies were already published. So the second improvement with immunotherapy is coming from the implementation of Blinatumomab in consolidation. So for a long time now, we had access to Blinatumomab for MRD positive patients. And now, based on the results of the E1910 study that randomized for every patient Blinatumomab in consolidation, we have now evidence that Blinatumomab also benefits to a patient with a good response to induction phase. And so the results are very impressive and support that the Blinatumomab can be used for every patient, every young patient in complete remission for a consolidation. And in this context, even if the end of induction is not satisfying, if the biology of the disease is at high risk, if the patient achieves an MRD negativity after Blinatumomab, there is a question about to bridge or not the patient to allogeneic stem cell transplant, and that is a question to be addressed in the future.